Hi, my name is Jennifer Griffin, and I'm a clinical pharmacist for Harps Food Stores. At Harps, I currently specialize in medical billing, point of care testing and treatment workflow, protocol writing and implementation, and marketing our clinical services. I'm so excited to be speaking today with you, Dwayne.
Thank you very much. I'm Dwayne Jones. I am the regional pharmacy supervisor and the clinical director for Harps Pharmacies. Happy to be here and thank you all for joining us for this series. So, Jennifer, you can kick it off.
Dwayne, with our introductions, I also want to add that a part of our job is we also work in the pharmacies half the week. So
Yes.
all of these clinical programs, all of the protocols that we write and we implement, we're actually living out on a weekly
Great.
basis in our pharmacies. So I always like
Absolutely.
to add that. But just to give some insight to those listening into our conversation today, I want to talk about our pharmacies and what services we've implemented over the years. We started doing testing a couple years before COVID. Um, we've always prided ourselves in being very forward thinking, very innovative. And so we started testing a couple years before COVID. So we were really set up whenever the pandemic started. And now that's really just grown to us offering point of care testing and treatment. So for strep and flu as well, we're doing oral contraceptive prescribing, A1C testing, and more. And we're medical billing for those in our pharmacies. We also built Medicare Part B for vaccines. We've been doing that for quite a while in all 39 of our pharmacy locations. And as we talk through this series, our insight and our experience comes from implementing and maintaining these programs within a small regional chain. So, Dwayne, you've been with Harps a whole lot longer than I have, and you've experienced this whole shift in our scope of practice.
It's been so much fun. I've been here for almost 18 years now, and 10 years of that, we've really focused on clinical. We saw the need when our MTM started with Part D plans, and we wanted to make sure that we were workflowing all of our clinical programs so that it was not going to be an imposition, but it was going to be an enhancement to our services. So workflow has been really, really essential for us to be able to add these programs and add them without adding any additional staff. That
Mhm.
was key to us, is because efficiencies lead to profit. If you've got workflows in place, you can feed all types of clinical programs into your pharmacy if you're utilizing all the tools that you should be utilizing. And we'll talk about some MedSync and some of those things as far as workflow is concerned a little bit later. But yes, it's been a great, great journey. And the thing I think that's really been rewarding to me is to see how the pharmacists have really thrived in this. They've enjoyed it. Change is never fun and it's always a little difficult. But once they embraced it and got through the change piece of it, you can ask any of our pharmacists and all of our programs we've implemented, they would never go back to the way it was before. Never. They love the programs. And Jennifer, what you said is the key is we develop our protocols, but we also work every day, well, 3 days a week in our pharmacies so that we can understand how it's going to impact our pharmacists as we roll them out. So that's what we want everyone that's listening here to understand is that these are tried and proven processes that all you have to do is just implement them in your pharmacy. And we want everybody to be successful. We learned a long time ago, it seems like pharmacy, it's been, if I've got this real neat program, I don't want to share it because I'm going to give away a competitive advantage. And we learned a long time ago that if we help others, we help ourselves. And we've got to
Mhm.
help the entire profession. I think, Jennifer, that's at the core of what we do every day. And that's why we're so excited about this series.
Absolutely. And we have had so many opportunities to travel around and speak about what we're doing. And so we're really trying to just get everybody on board, share whatever we can from our successes. Because if we can implement these clinical programs into 39 of our pharmacies that have different layouts, different prescription volumes each day, different patient demographics, you have different um, just a different feel of the pharmacy with the different personalities. We can implement these programs in all of our pharmacies and it works well. And so we know that if we can provide this to other pharmacies, that it can work in their pharmacy as well. Talking about, Dwayne, sit on so many different committees and boards. And so you have this good global perspective of where pharmacy has been, how it's evolved over decades. And so let's talk a little bit about just the current landscape of pharmacy and what you think is coming and why we need to get on board with this now.
This first initial program in this series is really pretty much about the why. Why do you need to do this? Why is it important that I do this now? Why is it important that I implement these programs, that I have a workflow system in place? Well, the reason being is because, like you said, Jennifer, I do have privilege to be able to sit on several different boards across the country, and I can see what's happening in the groundswell that's starting to take place. We've been talking for a couple of decades about provider status and about, we should be paid for our services. Well, now it's becoming a crucial tipping point in this country as far as access to care. If you look just from the American Association of Medical Colleges, they have two studies. One states that we need currently an additional 200,000 providers in this country for everybody to have equal access to care. Yet at the same time, in the same study, they cite that 20% of all the practitioners, PCPs that they have, are 65 years of age or older. And another 22% are between 55 and 65. So you're looking at losing 42% of your providers in the next 10 years. And there's no alternative. How do we address that? Well, it's become really evident now, and I think you'll speak to this a little bit, that the fact is that there is a pharmacy within 5 miles of 90% of the population. So why aren't we using, and the director of CMS just said this in the Rural Health Transformation Program, pharmacists are accessible, and he said it multiple times. He said it in the Aspen Institute. He's also said it just recently within the last 2, 3 weeks on a national program that pharmacists are accessible. We need to utilize them. So oftentimes people don't understand the scope of our practice every day.
Mhm.
We have over 1,000 hours more education post undergrad than most PAs and definitely nurse practitioners. So we actually have the knowledge base to be able to prescribe. We
Mhm.
know what our scope of practice limits are. We operate by protocol, so it is standardized within all of our pharmacies to provide the same level of service. And
Mhm.
so that is becoming a key focus today. And as we start to see PBM reform and the pressure on changing this model, now these plans that have been pretty much dictating how things are operated and living on the financial rewards of rebates, and those are going to go away. They're looking for alternative models. And then there's this pressure from CMS that says in 2030, we're no longer going to pay for fee for service. It's going to be a value-based program. The only way you can have a true value-based program where you affect adherence, decrease drug interaction errors, drug errors and drug interactions is by employing that pharmacist and putting them at the center of care. So now we have got data to show that. We've
Mhm.
got data to show over the last 2 to 3 years we've been involved. Unfortunately, Arkansas has had the opportunity to be at the forefront of a couple of those pilot studies to see that we have actually impacted decrease in hospital visits by as much as 33%. Now that's a huge, huge success. That's a huge number. So now, as we start to look across this country, and I have the opportunity to work even with some of the largest consulting companies in the United States, and they're saying we need a new approach to healthcare because it's changing so rapidly. When we start to share with them what we can do and the success we've had and the reduction in hospital visits, like this is great because this is a great opportunity for us now to go sell this to the plan to say, hey, here's the way you're going to save money. Here's
Mhm.
the benefit to you is the fact that we can put pharmacists in this equation. We improve adherence. You improve adherence. You decrease hospital visits. You decrease emergency visits. You have healthier workers. You have healthier employees. That alone is worth millions of dollars to these companies. So now that we're starting to see this aha moment, and I can tell you this last year, I was invited to one of the big, largest plans in the United States as a pharmacist to be at their national sales conference. First time in history that's ever happened. That's
Wow.
why you and I are saying today we have
Yeah.
got to get people on board because it's coming. And when it's coming, you're going to be paid for these services. I'm talking about in Arkansas, we get paid for test and treat, just like a mid-level provider does.
Hmm.
Time codes. We get paid for oral contraceptive prescribing and counseling, just like they do. And now they're looking at getting us involved in diabetes and hypertensive counseling because they've seen how much money they've saved in the first year of just having us do these point of care tests as opposed to them going to urgent care or to a primary care physician because our program is protocol driven. We don't prescribe antibiotics if they are negative. We don't give them a chest x-ray. We don't give them additional medication that they don't need if they test negative.
Hmm.
This is the facts are starting to come out to say this is why pharmacist driven protocols are so important. There's one study that was done by a company that manufactures the largest company that manufactures testing equipment in the whole world, and they, in conjunction with a couple of other associations, did a study. 52% of all antivirals that were dispensed last year were dispensed empirically. Those patients were never tested. And of the ones that were tested, only 27% tested positive. So you can see the waste. I mean, just the waste of number one, prescribing unnecessary prescriptions, but also antimicrobial stewardship. It's so important because now we're not dispensing medication that people don't need. We're not contributing to resistant strains of antimicrobials that are going to cause more problems in the future. So now healthcare is starting to see there's a tremendous value of having these pharmacists who are accessible within 5 miles of 90% of the population to have provide this care to these patients. Now these patients are actually getting consistent, regular visits and good care from people that they know and trust. So
And
that's
Dwayne,
that's the reason why we're so excited. And you can tell I'm passionate about it because I see this happening. And it's like I've been waiting for 20 years for this to happen. And so it's really exciting for me.
And Dwayne, I can speak from personal experience whenever we have patients come in to receive testing and treatment services, whenever they do test negative, and it's an education opportunity for us to talk to them about here's why you don't need an antibiotic today. Here's why you don't need an antiviral. And I haven't had one situation where the patient was upset with me for not prescribing that because it wasn't like I was leaving them hanging. I was providing that education. And then I would walk out into the front end and I would show them, here's what I can recommend to you to help with your symptoms, to help just get you through it, get you to the finish line, and just help your symptoms. And nobody has been upset with that. Once you educate them and get tell them why you don't need this, because we know with all medications there's potential harm. There's always an adverse effect that can occur from a medication. So if we can just prevent that altogether when it's completely unnecessary, I think we're doing a good job. Um,
We we roll out a new program. When we rolled out test and treat, we had some pharmacists like, well, I don't know if we should be doing this. I don't know if I want to do this. I don't know, how am I going to have time to do this? But once, and here again, because we work in the pharmacy and we've actually gone through this before we rolled it out, once they start the test and treat, and they get the feedback from the patients, it's like, I'm ready to go. I want to do more of this. So our biggest naysayer when we first started goes, well, I don't know. He had like 10 different objections to why we shouldn't be doing this. So we addressed them all. And I'll never forget the day he called me after work. He said, boss, he said, I did my first test today, strep test today. It was a breeze. I'm loving it. I'm ready to go. Let's bring it on. Let's do it. It's so rewarding the feedback that you get from the patients. And, it's actually economically pretty good thing for us to do within our pharmacies. We have one pharmacy. This has been just recently, Jennifer, that he had a mother and three children, and he did tests on them all. And I mean, we billed for that. It was like $400 that we received back for that service. They were elated to be able to get it done at their local pharmacy. And if you start to look just financially today, with pharmacists being really strapped with low reimbursement, now that pharmacy would have had to fill about 250 prescriptions to make that same $400. And yet the gratification he got from that was much greater than filling 250 prescriptions. So,
Absolutely.
there's so many positives from doing this and being involved in test and treat and medical billing. And that's
Mhm.
really the focus now is medical billings.
Mhm. Yeah. And so medical billing for our clinical services, it's a way for us to get paid for what we actually learned in pharmacy school. And I've talked about this a lot since becoming a pharmacist, but pharmacy school, it provided me with all the tools to be able to make independent medication related decisions. And Dwayne, you talked about how much more education we get than some of these other providers. And I'm not saying that to bash other providers. I'm not saying that to say that we're trying to replace them, but I'm saying that to show that we have the capability to prescribe, to make these specific decisions. And so, like during pharmacy school, during exams, we were given patient cases and we were asked, what medication would you maybe initiate for this condition? And we were the sole decision makers once given the diagnosis. And so it was difficult getting out into practice and being completely unable to make these decisions. It felt like I had this wealth of knowledge that I wasn't getting to really use like I had hoped. But now that we're able to provide these services, I get to sit down and, for example, have a conversation with a patient about oral contraceptives and potentially end up writing them a prescription and getting to bill for that encounter like a provider. And that right there is what I went to school for. In these situations, I get to learn about the patient and use my medication expertise to select the perfect medication to fit this patient's needs. And like you said, it's a lot more rewarding than just rushing through verifying 250 prescriptions. And it just shows me that we as pharmacists, we have the capability to do so much more with our knowledge.
Even the entities that are purchasing the health insurance are now starting to realize that there's a better method. And I think a lot of the advocacy has drawn awareness to a lot of the fallacies of the program and health insurance. It's been in the last couple of decades. And, education is great. Knowledge is power. And so we need everybody to be knowledgeable. The great thing about what I see is developing in healthcare today, Jennifer, is that it's a win-win as we're talking. We're talking to the plans, we're talking to insurance companies, we're talking to employers. It's a win for everybody. It's a win for the employer, the plan, for the pharmacy, and most important, it's a win for the patient. And you and I, that's the core of what we do every day. If we put the patient at the center of care, then healthcare costs is going to plummet. But most importantly, we're going to have healthier patients and we're
Mhm.
going to be more rewarded every single day. And that's where we're headed. I promise you, that's where it's going. And every way that I turn now, and every committee that I'm on, every board that I sit on, I see this aha moment occurring. And sometimes to me, it's like, it's really obvious.
Yeah, it's like a no-brainer. Like
Yeah.
why would you not get
It's
pharmacists
like bad
involved?
habits. We've been
Yeah.
doing this thing this way for so long that I don't know. And literally, sometimes we have to tell them, this is how you have to start selling this now. And then
Mhm.
whenever they realize, well, this makes a lot more sense, then it becomes this excitement within their organizations, which is really fun to watch, actually. So we're
Mhm.
there. I just want to encourage everybody that, get on board, start working, start delegating tasks, and we're going to go through this series and give you some tools. So.
Yeah. Dwayne, I love whenever you share the data backing up the undeniable impact that pharmacists can have on patient outcomes. And we use this data so often when talking to payers, when talking to legislators. And you mentioned that sometimes pharmacists can be our toughest critics too. And so we use this data to encourage other pharmacists to get involved in offering these services to their patients. Um, and a study that has just stood out to me since it came out, it was a 2023 JAMA study, and it resulted in, and I'm just going to quote it because I'm not a
Okay.
biostatistics person, but they found that at the population level, a 50% intervention uptake. And this is talking about pharmacists prescribing interventions to improve blood pressure control, and just the economic value that that can bring. So, a 50% intervention uptake was associated with $1.137 trillion in cost savings, and it would save an estimated 30.2 million life years over 30 years. And so the conclusion of this study, it suggested that a pharmacist prescribing intervention to improve blood pressure control may provide high economic value. And the necessary tools and resources are readily available. And so I love that statement in that conclusion. Like pharmacists are primed and ready to go. Dwayne, you talked about how close pharmacists are to everyone. Like there's a pharmacy so close. And
90% of the population. And so
yes.
they're accessible and they're
Yes.
knowledgeable. And the thing I love about that study, Jennifer, is that it's it's JAMA's own study, Journal
Yeah.
of American Medical Association, and those are facts. And to me, it's a testimony again to we haven't looked at an alternative way to employ pharmacists because we've been so involved in the current processes that we haven't taken time to say, hey, there's a better way. And
Hmm.
yet we have the data here to support that there's a better way. But until we're forced, and that's why advocacy is kind of causing this to happen, until we're forced to change or that someone says, gosh, this makes so much more sense, we just continue down the same path. Well, I'm telling you, that same path now has become, they've squeezed everything they can squeeze out of us and out
Hmm.
of the system. So now they're saying we have to modify the way that we're going to conduct business in the future, which is going to be better for everybody. And they're going to find a better pathway for themselves too. So that the evidence of this data is it's there. I
Hmm.
mean, time after time after time, we can quote so many articles and data that shows that the impact that pharmacists has on healthcare of the United States. You got to remember, and I've said this so many times, probably in another one of our webinars here, is that 275,000 people die every year in this country from non-optimized drug therapy. That's not a disease state. That's just drug interactions, drug errors, non-adherence. That's a tremendous number of people. And to put it in perspective, the longest war we've had in modern day history is the Vietnam War. In 7 years, we lost 56,000 lives. 5 times that many people die in this country just from non-optimized drug therapy. Well, you put the pharmacist in that equation and give them the tools, compensate them to take the time to interact with those patients, we can reduce that number. If we're only 10% successful, wow, that's 27,000 lives we saved in a year.
Exactly.
The other thing is it also costs this country $300 billion a year because those people wind up in the hospital. That's a tremendous cost. And yet, if we can be in that equation and start this process of reducing that number of deaths and having more healthier patients, then we have accomplished more than what we could have imagined in a short period of time. I'm telling you, in the last 2 years, you hear me say this, what's happened in the last 2 years that we've seen in this transformation has been mind-boggling. I had talked to a pharmacist yesterday. He said, I would have never dreamed that I would have seen what's happening today, that's happening so fast. And so we say these things because we want to encourage you, because you don't often hear these things. You hear a lot of the bad, you hear about what's going on, people are sorry, but you're not hearing what's actually happening at the grassroots level. And this groundswell that's starting to take place. And when it takes off, we want everybody to be ready to take advantage of this.
Absolutely. Well, Dwayne, I'm excited to work through this multi-part medical billing series with you. And I hope that people can get a lot out of it as we share our experiences and we walk through MedSync, workflow, setting your
Yes.
pharmacy up for success. We're going to work through the revenue cycle management process. We're going to talk about the provider mindset. That's something that we talk about all the time. Again, just empowering our pharmacists to use that knowledge that they do have. So it's going to be a good series, and I'm excited to work through it with you.
Yeah, it's going to be so much fun because sometimes you hear things that are they don't come from a standpoint of practical application. When we have our pharmacists, and you can call any of them and say we love this because it works. And there's no reason why it can't be replicated. And that was our goal when we created all these things, was to be able to replicate them and share them. So we really hope that we get a larger audience that really starts to employ these protocols and utilize them so they can help increase patient outcomes and have a happy life with all the great experiences we have with those patients saying, thank you. This was such a great opportunity, a great experience. So gratifying. So yes, I'm excited about it.